The skin is preferably not lifted with forceps to prevent crushing. The needle punctures the skin perpendicular and ends in the subcutaneous tissue. Make sure the skin is punctured at the other side at approximately the same distance as the insertion puncture. The thread is pulled through to approximately 2 centimeters off the distal end to prevent unnecessary movements. Then, a surgical knot is made with the needle driver. Both thread endings are cut. Here it is shown again. All the knots should be placed on the same side. To save time, it is also possible to place the needle in one movement through both skin edges. Cut the thread close to the skin on the unknotted side. This limits the length of the dirty thread that has been on the outside, which is pulled through the skin, and lowers the risk of contaminating the healed skin. The needle punctures the skin perpendicular and ends in the subcutaneous tissue. The needle is then placed back on the needle driver by forceps. Make sure the skin is punctured at the other side at approximately the same distance as the insertion puncture. The thread is pulled through to approximately 2 centimeters off the distal end. Then a surgical knot is made with the needle driver. The needle is placed at the same distance as the other suture on the skin. It is placed back on the needle driver and punctures the other side of the skin at approximately the same distance. This is continued until the end of the wound. A surgical knot is placed using the loop of the last suture in the same manner as the short thread ending. Here it is shown again. The short end of the thread is cut as it is too long here. The assistant should not put too much tension on the thread. If the thread is too short at the end to knot by hand, it can be extended by placing a new thread through the loop and use this new thread to knot. Cut the thread close to the skin. This limits the length of the dirty thread, which has been on the outside and is pulled through the skin, lowering the risk of contaminating the healed skin. The skin is punctured by a perpendicularly placed needle, a little bit further away from the edges than the other sutures, placing the needle subcutaneously. The needle punctures the other side of the skin at approximately the same distance as the insertion puncture. The needle is turned 180 degrees and is inserted superficially and closer to the wound edges using the backhand technique, placing needle intracutaneously. The needle punctures the other side of the skin at approximately the same distance as the insertion puncture. A surgical knot is made. Here it is shown again. It is also possible to place the needle in one movement through both the skin edges. Grasp the knot and cut the thread at the other side. Try to cut as close to the skin as possible. This limits the length of the dirty thread being pulled through the skin. The skin is punctured by a perpendicularly placed needle a little bit further away from the edges than the other sutures, placing the needle subcutaneously. The needle punctures the other side at the same distance. The needle is turned 180 degrees, is inserted superficially, and is placed through both skin edges in one movement. The thread is pulled, and a surgical knot is made with the needle driver. The short end of the thread can be cut if it is too long. The running suture is continued. The vertical mattress suture is used to evert the wound edges and facilitate wound healing. The last suture is pulled but not too tightly. A surgical knot is placed using the loop of the last suture in the same manner as the short thread end. The skin is punctured by a perpendicularly placed needle a little bit further away from the edges than the other sutures, placing the needle subcutaneously. The needle punctures the other side at the same distance. After turning 180 degrees, the needle is inserted half a centimeter from the previous suture. The thread is pulled and a surgical knot is made. All knots should be placed at the same side. The skin is punctured by a perpendicularly placed needle a little bit further away from the edges than the other sutures, placing the needle subcutaneously. The needle punctures the other side at the same distance. The thread is pulled and a surgical knot is made. The thread is cut and the needle is inserted half a centimeter from the knot, placing the needle subcutaneously. The needle is turned 180 degrees and is inserted at the same distance. The sutures are continued until the end of the wound. The last stitch is not pulled tightly. An Aberdeen knot is attempted here, but the thread gets mixed up. A solution for this problem is to cut the knot open, pull the last loop back to create room to place a new thread through the loop. With this new thread, the knot can be made. At the end, all the threads can be cut. The skin is elevated atraumatically with surgical forceps. With a forehand technique, the suture is placed from deep subcutaneously to superficial intradermally. The suture is placed on the contralateral side from superficial to deep. A needle is picked up with forceps. A deep surgical knot is made. Make sure the threads are pulled in the direction of the wound, so the edges are pulled towards each other. By pulling the threads to the sides, the wound edges would be pulled apart. Both thread ends are cut. Here it is shown again. Note that an uncolored thread is used. In the previous example, a colored thread was used for educational purposes. Anchoring the knot can be performed in several ways. The first is to place the needle intradermally 1 stitch length away from the apex of the wound. From the apex, a stitch is placed and should come out intradermally a slight bit further than the insertion of the first suture. A surgical knot is made. Make sure the threads are always pulled in the direction of the wound edges. The short end is cut off close to the knot. The running suture is continued subcuticularly. At the end of the cut, the needle comes out in the corner of the cut. The final suture is placed back and should come out approximately at the insertion point of the previous suture. The thread is not pulled through completely, leaving a loop which is used to make a knot. The excessive thread is cut, and the knot is buried by stitching the needle away. The thread is cut as close to the skin as possible. This time the suture is anchored in the apex of the cut by inserting the needle deeply and extracting it superficially. Then, a knot is made. The short end is cut, and the running suture is continued subcuticularly. The forceps can be placed on the wound edge to pull the skin and facilitate in puncturing the skin. Make sure the needle comes out right adjacent to the forceps. To facilitate puncturing of the skin, the forceps can also be placed behind the insertion point. A loop is made in the backhand. Do not place the knot in the corner. This may lead to ulceration. The last stitch is made from superficial to deep subcutaneously and is on the other side inserted from deep to superficial. With the incompletely pulled through suture loop, the knot is made and excessive thread is cut off. Finally, the knot is buried. Anchoring the knot can be performed in several ways. Here, the needle is inserted subcutaneously, coming out superficially at the apex of the cut. The needle is picked up, a knot is made and the short end is cut off close to the knot. Then, from the apex, a stitch is placed intradermally and should also come out in the same layer. The running suture is continued. An Aberdeen knot is made. For the three-corner suture, the needle is also positioned perpendicularly to the skin and the needle is placed in the deep dermis. Try to stay in the same layer, the deep dermis, the entire time. For the second and third part, the needle is again inserted in the deep dermis. The suture is finalized by a stitch back to the original insertion point. A surgical knot is made. The skin is closed with staples. Assistance to evert the skin edges with forceps is required. Place the stapler correctly above the wound edges and touch the skin with it. Do not push. Compress the handle to release the stapler. The scalpel is held in a pencil grip. The skin is pulled tight and the scalpel is placed perpendicularly to the skin. In one smooth movement, the skin is incised. The lesion is dissected off. To enable closure, the skin has to be undermined on both sides. After undermining, the wound can be closed with standing simple sutures.